Welcome to our TEPR webinar series today on lessons from the COVID-19 pandemic. We're delighted to have with us Dr. Amesh Adalja, a senior scholar at the Johns Hopkins University Center for Health Security. So welcome to our alumni from Carnegie Mellon, from the TEPR School. We're glad to have you with us today. I'm going to do a couple of announcements as we go in to make you aware of other things we have going on. We do want to make sure that all of you have the opportunity during this time when most of us are working remotely to have an opportunity to connect with the alumni community. So if you haven't logged in to our new Salesforce community, we'd love to have you do that. You can go right online to community.cmu.edu and log in. We also have some upcoming TEPR virtual events that we want you to be aware of. We've got the second in our series of what we call TEPR Faculty Home Office Hours with Tim Derdinger, our Associate Professor of Marketing and Strategy at the TEPR School. That's on Thursday. There still are a few seats left in his virtual classroom there. So if you'd like to sign up for that, you can go ahead and do that online. Our next webinar will be next week with Associate Dean Alan Scheller-Wolf talking about sustainability, a business imperative. That's on May 21st. And then in June, we'll follow up today's discussion with Lawrence Alice, who's Associate Professor of Economics and International Scholar and top scholar at Carnegie Mellon, who's going to talk about how COVID-19 will impact the global economy. So we hope you can join us for those. But today I'm very happy to be able to introduce one of our alumni, also a physician, a scholar, an educator, Dr. Amesh Adalja. I can't explain all the initials after his MD, but he'll be able to do that if you like. He received his undergraduate degree in 1995 from the TEPR School of Business, then GSIA, and graduated from the American University of the Caribbean School of Medicine. We're very happy to have Dr. Adalja with us. We've got lots of questions. If you haven't had an opportunity to read on his background, I haven't been able to do justice to all the things that he has accomplished already in his young career. It's an impressive background. He's spending a lot of time these days being interviewed. He was on KDKA earlier today. And YouTube, CNN, Fox, NBC, the Wall Street Journal, NPR, he's been really requested by many media outlets to give some expert commentary. Where I first got a chance to hear him speak was at our TEPR School of Business, where he spoke to our students who are part of the healthcare club. He came and did a couple of excellent presentations, including one, Ask Me Anything, that's inspired us to arrange this webinar today. So Dr. Adalja, thank you so much for joining us. We're happy to have you with us. And I wanted to ask you first, if I could, what inspired you to go into medicine? You started out as a business student and ended up into medicine.
Both of my parents are physicians, so that was something that was kind of always in my mind. And I started at CMU as a double major with biology and industrial management at that time. And then I kind of got a little bit burned out with the science at that time, maybe because I overloaded myself with too many classes at once. And I had taken so many AP classes and I was only 17 and I was taking the second semester sophomore courses. And I think I found that I was I got much more interested in finance and business. And I still have a very strong interest in all of that. But what ended up happening is after I graduated, I started to feel that I wasn't doing what I really wanted to do, that I felt like I was not challenging myself. And I was really interested in, at that time, even in infectious diseases. And I knew when I went into medicine, I was going to go into infectious diseases and work in pandemic preparedness. And so I kind of just made that switch. And I do think that one of the advantages I have has a lot to do with the fact that I have an undergraduate degree in industrial management, because I'm able to really see things in a different way than many people do. I have a lot of statistical and econometric backgrounds from, if any of you have went through the CMU program, know how much math you have to do. So that really helps me when I'm trying to understand a mathematical model of an infectious disease, or also to see some of the cascading impacts of an infectious disease. So that's kind of the short story of how I ended up in medicine.
Well, we know that you're a practicing clinician, an active physician, but you also have an important role as a senior scholar with the Johns Hopkins Center for Health Security. So could you tell us a little bit about the center, how you got involved, and what the center really does?
Sure. So the Center for Health Security is a think tank that's focused on infectious disease emergencies. And we work at the public policy level where we're talking to policymakers, talking to people in government and in non-governmental organizations, trying to increase the resiliency to infectious disease outbreaks, whether they're caused by a natural event like this coronavirus or an unnatural event like the anthrax outbreaks in 2001. And we work on all of those topics. The think tank is based in Baltimore. And how I got affiliated with it was there was a time that it was affiliated with the University of Pittsburgh Medical Center, or UPMC, from about 2003 to 2017. And I was a training doctor at UPMC at that point. And it was kind of this really serendipitous thing that they were affiliated with this think tank. So I started to spend time there around 2008 and then joined them completely. They've always been in Baltimore, but they then re-affiliated. They used to be affiliated with Hopkins, then they were UPMC, and then back to Hopkins in 2017, but always in the same building in Baltimore. So that's how I ended up being a Hopkins person based in Pittsburgh, although I do go back and forth between the two. And the think tank was founded by D.A. Henderson, who was the man who eradicated smallpox from the planet. So it is a very high-profile think tank and has really affected change in this field.
Thank you. Has there ever been a time when your phone has been ringing and your texts have been coming in than they have during this coronavirus?
No, this is probably the busiest I've been in my life. I think the Ebola outbreak was pretty busy. I was doing a lot of media and a lot of stuff at that time, but this is a whole new different level that took a while to get used to.
Well, I do want to encourage all of our alumni that are watching today to go to the Johns Hopkins Center and look at some of the articles and research papers, white papers that you and your other scholars have written on these topics. I think they're very interesting. Today we've received lots of questions from our alumni audience that we're going to try to go through today. I tried to bundle them into 3 categories. For our other alumni that are on and maybe we'll have an additional question, you're welcome to add it in the question function there. But right now, we'd like to talk first about the origins of the pandemic, and then maybe talk about some of the current issues and advice on that. And then we'll talk about the lessons from it. But maybe you could start with just kind of, where are we now? What are some of your opening comments you'd like to share with us?
So we're in the midst of a pandemic, and this is going to be something that doesn't disappear, that's going to be with us for some time. This is an efficiently spreading respiratory virus. It's made its way into the human population, and it's what we say is it's now become endemic, meaning it's now something that we're going to have to face. We're going to be faced with. This has caused major disruption all throughout the world. Many people thought that pandemics couldn't do this anymore, but many of us in the field knew that it would be able to do this, especially based on the fact that decisions that are made in response to the virus can be very wide-ranging, often taken for political reasons rather than actual scientific reasons, and that can magnify the threat of the pandemic. What we're seeing in the United States is basically the country most affected by the pandemic right now, with the largest number of cases, largest number of deaths, and I think you're probably asking more questions about how the response went, but you can see that there were early missteps that magnified itself and got us to the situation that we're in right now. The key question that you need to keep in mind looking forward is you have to remember the virus is here. It's not going anywhere until there's a vaccine. It takes usually years to make a vaccine. We are going fast as we can, but I don't think you can expect a vaccine. It's really optimistic to think we're going to have one in 12 to 18 months or sooner. So you're going to have to make a lot of decisions on your own about how to deal with this risk as states open and decide what your risk tolerance is and what your risk aversion is. And it's not going to be the same for everybody. It's not going to be possible for doctors like me to be able to tell you, yes, you should do this. No, you shouldn't do this. It's going to be a lot of that's going to happen in the future. And I think that's going to be very difficult for people to look at. And what the real metric that I look at is what is the hospital capacity? Because social distancing procedures were put into place in order to preserve hospital capacity. So we never exceeded hospital capacity. And people got very nervous about what happened in Italy and what happened in New York City. And it seems to be, for the most part in this country, we solved the hospital capacity problem with a lot of stress in New York. And not everything that happened in New York is extrapolable to other places. And those of you who are watching from Pittsburgh know we've been handled this fairly well here. But that's going to be the metric going forward, is keeping the case count to a level that does not end up bubbling over into hospitals and putting hospitals into crisis. And I think we'll probably talk a little bit more about that in the questions, but that's kind of my general overview of where we are. It's been a rocky road, and I think the early missteps got us to this bad situation we ended up in March and April. And
it changes every 5 minutes.
Right.
Yes.
It's probably changed already.
While we're talking, yes. There was initial questions about where the COVID-19 originated, and was it originated from nature? Was it something that was man-made? How do you answer those questions? I know they're out there in the media all the time.
Sure. So this virus there's no evidence that this virus was man-made. If you look at the genetic sequence of it, there's no evidence that this was genetically engineered. We know that coronaviruses naturally live in bats. And when they get into humans, they often use an intermediate animal. We don't know what that animal was, but it looks like this is a natural virus. Then the question arose, was this a laboratory accident? Did a lab worker get infected working with a natural strain? That's something that's going to be very hard to answer. People have raised concerns about some of the labs in China, specifically about their biosafety. And biosafety is something that we've been harping on for some time because, for example, even in the United States, we've had live anthrax shipped. We've had very dangerous flu strains shipped inadvertently. We found smallpox vials in a building in Bethesda. So all of that is something we really emphasize. And people did raise concerns about the biosafety at the Wuhan lab. But there's no evidence at this point that points to anything but a natural origin, although we have to be careful and mindful about biosafety and making sure that no worker got inadvertently infected. But there's no evidence at this point to say this is anything other than a natural outbreak.
How could we have recognized the seriousness of the virus while it was still in China and before it actually came to the U.S.? Was there an opportunity to notice that early?
There was. Many of us in the field did. If you go back and I look in some of the media interviews in January that I was doing, as soon as we realized that this was a community spreading respiratory virus, meaning this just wasn't animal to human with some sporadic human cases, but this was spreading in the community, that should have changed everything, meaning that type of a virus with that type of spread is not going to be something that remains in one country. And indeed now, we were hearing about this in January. Now you can look and see that there were cases around Christmas time in France in people who hadn't even traveled to China, telling you that this virus was spreading surreptitiously all around the world, probably at least since mid-November. And had already seeded other countries. So this was something we should have immediately said, this is a pandemic threat. This is not something that we're going to contain in China. We really have to get our hospitals ready, get our diagnostic companies ready, get our health departments resourced, and tell people to prepare for this virus to be here. This is not just a travel-related illness. This is going to be something that's among us. And indeed, I think we will see, as we do more studying, that we'll realize that this was in the United States, likely in December or maybe even earlier.
Wow. Well, why were authorities in the U.S. slower to understand the infectiousness of the virus?
I don't know that they were slower because I've been taught by some of those people that are the authorities here, that I've interacted with them. There is a lot of politicization going on here, and I can't, you can't minimize what effect a political atmosphere puts on and the pressure that puts on science. I think many of them thought that they would get it. I think most of them recognized what was going on. Maybe they did not think that some of the early missteps would happen in terms of the diagnostic testing rollout. And many of them were also looking at the SARS virus. And remember, SARS is an epidemic that occurred in 2003. Very, very similar virus, same family, very close genetically, causes some of the same symptoms. However, SARS wasn't very efficient at transmitting between humans. And at that time, the Chinese government kept saying, well, it's not transmitting efficiently between humans. So people may have been taking China at its word at that point, and then trying to extrapolate from SARS to COVID. And this virus spreads much more efficiently between humans than SARS ever did. And that may be part of the early initial missteps, coupled to the fact that our diagnostic testing was bundled from the beginning, and some of our contact tracing, especially New York City, wasn't done appropriately. But it's still one of the main questions that I would want to ask, because I don't understand, the textbooks that are written by some of our experts, why what they've written in textbooks wasn't followed is an interesting question.
So bringing up New York City, kind of the epicenter of the deaths and cases in the United States, why was it impacted more than, say, LA, where there were more travelers from China coming in? Is there an answer to that?
So a couple of things. So you gave me a really good lead here. So you said travelers from China. So remember I told you that this was already in France at Christmas. And if you look at the sequence data from people that got infected in New York, they didn't get it from China. Those were European strains of the virus. So that tells you, when you say, we're going to only test people that traveled to China in the last 14 days, that we're going to institute a travel ban on people from China, but you don't do, but in the cases all came from Europe. So that already warped the way people thought about this. This is a Chinese disease. When New York got seeded with the European strain of the virus, there were early missteps there too. Their case contact tracing wasn't done very well. And what you have to remember about New York is that New York has such a high population density, much higher than even the second tier cities in the United States, that any kind of infectious disease that spreads efficiently from person to person is going to have a very easy time in New York, much easier than in a place like Pittsburgh, for example. You have so much density, so much reliance on public transportation. And you have hospitals there that even on a good day are stressed. If you've ever been in an emergency department in New York City, you think you're in a war zone sometimes. So they have very little excess capacity, especially the government hospitals. So many hospitals like Elmhurst, which you heard a lot about in Queens, that's owned by the city government and the New York City Health and Hospital Corporation. They have a hard time actually being able to meet surge. And even back in 2017, 2018, during a very severe season, Elmhurst almost went into crisis. And then you have hospitals like University Hospital Center in Brooklyn, which is owned by the state government. Again, another hospital that got hit hard. And New York City's had hospitals close over the last several years. So they basically are the canary in the coal mine. And I think all of that coupled together got New York to the position that it was in and really set the tone for the rest of the nation. And we're learning now that not everything that happened in New York City was extrapolable to the rest of the country.
Well, you began in your opening comments talking about that it's going to be with us. Are the measures stopping and limiting the growth, spread of it, merely slowing the rate of the spread until a vaccine is in place? Is that the most we can hope for at this time?
Most of the measures weren't really to slow it to the point for waiting for a vaccine. It was basically to slow them so that hospitals could be in a better position to deal with it, that we could get diagnostic testing scaled up, that we could make sure that our health departments were resourced enough to be able to do contact tracing. And once that was in place, you started seeing people peel back the social distancing. And obviously this has not been done exactly the same in every state. Some states have went ahead of what people would have recommended. Some states have done it on time. So there's a lot of variation in how governors are implementing those recommendations. But the key thing was, do you have hospital capacity? Do you have diagnostic capacity? And do you have contact tracing capacity? Then move forward and start peeling back some of the social distancing. But obviously not all of it. Go slow, titrate based on what you see in your hospitals and the number of cases. Because as you end social distancing, it is a simple biological fact. You are going to get more cases as people interact. And some of those cases are going to end up in the hospital, and some of those cases are going to end up dead. So this was not necessarily about stopping the spread or getting this down to zero or decreasing the number of deaths. It was really about making sure hospital capacity wasn't exceeded. Because the alternative then is to do kind of a lockdown until you have a vaccine, which could be 2 years from now. And that's going to have its own costs, including death costs from other conditions that go up during that period of time. So this was really about hospital capacity. And it's important to watch how people speak about this because they are very, very sloppy, but it's not very great. It's not a very great tagline, social distance in order to preserve hospital capacity. It's more about, so they like it to make it much more personal to get people to do it. But it really was at base about hospital capacity.
Well, what looks like the most promising potential vaccine or cure for the disease to you is one of the questions we've got.
Well, there's a separate question. So with vaccines, right now we're in a race to make a vaccine. There are at least 4 or 5 vaccines in the United States that have moved into clinical trials. Or actually, there's 2 or 3 in the United States in clinical trials, and then there's some in England, and then there's a bunch in China, which are hard to keep track of. We're moving really quickly. What's interesting about all these vaccines is most of them are not being done in the traditional manner. They're using what are called vaccine platform technologies, which are basically plug and play type of things. Like you have like I'll put it in computer game type of stuff for Carnegie Mellon people because they're so tech, like a Nintendo machine, and you switch out the cartridge, but the machine stays the same. That's kind of what we're doing with vaccine platform technologies. And they're using some interesting ones, using nucleic acid vaccines, just pure mRNA or DNA. I'm very interested in those. We're using ones where we use another virus to carry the coronavirus protein in. That's another interesting approach. I think my favorite, I think the mRNA vaccines that, for example, Moderna, which I have I don't own any stock in Moderna. That one is very interesting to look at. because people have really staked a lot on that type of vaccine because it does get you to a vaccine candidate very quickly. We still have to go through the clinical trials, but it gets you to a possible vaccine very, very fast. And then it's just manufacturing and studying it and understanding it. When it comes to cures, I don't think that remdesivir, which is the Gilead drug that just went through some clinical trials and heard some good data on, can be considered a cure. It's not really super beneficial. It gets people out of the hospital quicker. What we'll see eventually are what are called monoclonal antibodies, which is taking antibodies from people that recovered and trying to make a synthetic version of them. That's probably the most likely thing that will be like a cure. But that's also going to be something that we give to people that are in a hospital. It's not going to be for everybody because the simple fact is most people still get this and don't have any problems at all and don't need any medicines other than Tylenol, and they get better. But there are some people that are sicker and need these types of things in the hospital. So people have really focused on hospital-based therapies. There is nothing on the horizon that I see right now that's like a Tamiflu equivalent, which keeps people out of the hospital, which I think would be really game-changing because, again, it goes back to hospital capacity. If you can keep people out of the hospital, we can move forward in a different way.
Well, thank you. Another question was, how long from a point of exposure before the test would show positive? Is there any prospect for a more rapid test, an at-home test that someone could use?
So a test that has a limited of detection, so it's going to be a couple of days once you're exposed before you see it. The average incubation period is probably around 5 or 6 days, so you probably would test positive around 4 days or so on most tests for it. So that's probably how long it will take. The prospect of a home test is something people are really looking at. Right now, the FDA has given emergency use authorization for home specimen collection, meaning you can take your own nasal swab and mail it in. But there has been a big effort in the past several years to try and make home testing available, for example, for influenza, and they're trying to adapt some of that. We do have home testing for HIV, and so this is not something that's unprecedented, and people really want to do this because it would enable people to really be able to move forward and be very cognizant of what their status was, and it would solve a lot of the testing conundrums that we're in if people could just do this at home and not have to deal with standing in line or getting an appointment or having it sent off. So that is something people are working to get to.
Good. There was another question came in and wanted to know, it appears that Sweden took a measured approach to dealing with the coronavirus, and what can we learn from them and avoid some of perhaps the economic damage that we continue to experience? How do you see that from kind of an economic and another experience?
So there's definitely a balance because the more you do an economic shutdown, the more unemployment you have, the more you tell hospitals they can't do routine procedures, the more that cost goes up. So there is this cost benefit analysis you have to do, and you have to make this balance. And that's something that you haven't heard a lot about because many people here are so laser focused on the virus that they forget about everything else. And we have seen, for example, decreasing rates of vaccination, decreasing rates of cancer screenings for cervical and colon and breast cancer. We've seen delayed starts in chemotherapy, people putting things off, and increases in alcoholism and increase in alcohol sales definitely has occurred. So we are worried about this, and it's something that has to be weighed appropriately. And eventually, it also comes to the fact that unemployment, if you can't work, you can't have food, you're not going to have any of the things that you need to actually live your life. So the economy, in the end, is people's lives because we know that unemployment and depressions do increase the rate of deaths from other issues. So Sweden took a strategy where they didn't do lockdowns, but it's important to remember that Sweden isn't completely normal in terms of what it was before this pandemic. Sweden does have a population where many people telecommute already, that many people work from home. They did a lot of voluntary social distancing as part of their plan anyway, and they have had a high death rate. So I think that this is not something that's obviously wrong. It's definitely a societal question that you have to have if you're going to go one way or the other. It may be easier to do this in one part of the world versus another part of the world. I think it will be really important to watch Sweden over the next several weeks to see, do they pay off? Does this pay off? But they are going to definitely pay a cost in terms of deaths for this. And I think that the United States took an approach where they use very blunt tools of economic shutdowns. And most governors, if you can look in Pennsylvania, for example, there were 25,000 exemptions of what was considered a non-essential business. So the fact that they had to grant that many exemptions tells you that they probably acted with too brought a stroke. And even Governor Cuomo in New York has said maybe some of those things didn't need to be closed. And you're seeing that you're seeing the fact that most people didn't right size this response. I think in certain places, broad shutdowns like in New York City were probably necessary so hospitals didn't collapse. But in many other parts of the country, it should have been more nuanced and more targeted. But I think that governors are afraid of risk, and if they're acting in the name of, quote unquote, saving lives, they're going to get a pass for doing so. And I think that's what happened, that they're very risk averse.
Well, that brings us into bringing the economy back online. And what steps would you advise to be taken to protect employees returning to offices that you think are going to be the most effective?
Well, I think if you're an employer, one of the first things you should do is think that you should probably do as much telecommuting as you can. That you should say, if you can telework, if you can do this from home, you probably should do it, especially for your vulnerable populations that are older or have other medical problems. You should make it as flexible as possible. You should think about business trips as well. Can it be done like this through Zoom, or do you have to be in person there to do that? So think about essential travel and non-essential travel. Think about how you might make social distancing easier in your workplace in terms of, do you space the desks differently? Do you have more hand washing stations? Do you have an employee health program that can help your employees if they get exposed or if they get tested, to get tested? Do you have a plan for exposures? And you should plan on seeing exposures in your workplace. This is a virus that's going to be with us. You're going to have lots of these issues pop up. And I think it's important that you come up with a plan to do it. I don't think you need to overreact or panic, but it's going to be something that you're going to want to have in place as you open up and as you deal with these situations, so you're not kind of scrambling at the last minute. And I think there are companies that are actually going into coronavirus consulting and white glove service to do this all for companies. It's very interesting to see how the market really tries to meet these needs pretty quickly.
Well, that brings up air travel. And some of us have jobs that involve a lot of air travel. Normally I'd be on a plane flying to alumni events all over the country and all over the world. When will you take a 10-hour flight abroad again, as one of our alumni asked?
So I'm pretty risk tolerant. I think if I'm going to get infected, I've probably already gotten infected in the hospital, and I had a mild case. So I tend to not have that much of a problem. The only thing that would dissuade me is of traveling internationally is getting stuck in some kind of quarantine in the country that I land in. And coming back. So if I want to tack on an extra 28 days to my business trip or my trip, then I think I would be willing to do that. But I think right now, international travel is really going to be constrained by the entry requirements and the exit requirements in different countries. So if you're going to go, you should prepare to spend a month on your trip.
Wow. Well, I know the Pittsburgh International Airport has teamed up with the Pittsburgh-based Carnegie Robotics to deploy autonomous floor scrubbers. They use UAV technology designed to kill the microbes in that. So what can airlines do? What can we do as passengers to protect ourselves when we fly?
I think that it's just kind of the basics. Try and social distance as best you can. Don't touch your face. Try to wash your hands as best as possible. If you see a big line at McDonald's, go to the other restaurant. Try to do as best you can. Nothing is going to be risk-free. It's important to remember that. This is all going to come down to your own risk tolerance. People ask me all these questions. Can I go here? Can I do this? Can I do that? But the answer is always going to be, it's up to you to make those decisions. I'm not going to be able to say anything is actually safe. Certain things are safer than other things, like, golfing versus sumo wrestling is probably, going golfing is probably safer than being a sumo wrestler. But I don't think anything is going to be without risk. So you got to really have to think about what your risk tolerance is, what your personal risk factors are for severe disease, who you take care of, meaning if you get sick, could you spread it on to your grandmother or some elderly person you live with? Mm-hmm. So keep all of that in mind and make these decisions mindfully. I don't think there's a right or wrong answer here.
Yeah, I think I received a lot of questions about how families should prepare for their annual summer vacations. Most of the camps are being canceled for their kids, but they're still planning should they go to the beach, should they go to the lake? What are your recommendations for family vacations? Any thoughts? Again,
I can't, there's not one to endorse. I can't say one is safer than the other. Obviously, if you're in the woods doing something like that, you're not probably going to doing something kind of outdoorsy. You're going to have less likely exposure than if you're deciding to go somewhere where it's going to be crowded, or if an amusement park opens up or something like that. But I think you have to look at your family and say, what are their risk factors? Do I have any children with asthma? Do I have any medical problems? and then try to make that decision. I think that you're going to have to move forward in this environment now, knowing the virus is ever present, and you're going to have to find a way to think about what's safe and what's not. I do think there's going to be a change in vacations, meaning more people are going to do more outdoors type of stuff, more local types of stuff that don't involve flying somewhere, less dependence on Disney and Universal and all of those types of amusement park type of vacations, and much more, I guess, more bare bones types of things that are going to happen. But I don't have specific recommendations other than that you're going to have to be wary of the virus, and some people are going to be tolerant of it, and some people are not going to be tolerant of that risk.
Well, we'll be coming back to some other questions that are coming in, but Major League Baseball, the NFL, college sports are all trying to figure out what they're going to do. What are your thoughts on that?
So I am on the NCAA's coronavirus task force. So it is something I've been thinking about a lot. And I'm not a major sports fan, but I ended up getting sucked into all of this and having to talk to everybody from the NFL Players Association to the PGA to everybody, trying to figure out what's safe and what's not safe. I think that a couple of things to say. I think that we won't see fans in the same manner that we saw in the past, that it's going to be very difficult to have a mass gathering, and most mayors are not going to want to have that many people in their town at one time. You can imagine how many people come here for a Steelers game and from all over. So I think that's really going to be something that's going to be difficult to have in the absence of a vaccine. The issue then becomes, how do you make sure that the players and the coaches and all of those people are safe? And I do think there's going to be some risk tolerance involved, but we're going to probably have to come up with a testing regimen of how frequently you test those individuals, and how you and what you do with exposures, and how to move forward with that. And I think that this is going to be variable. Certain sports are easier than others, like professional golfing is easier. I think tennis is easier. It's going to be harder with contact sports like football. So we're right now in the midst of trying to think about how this might work, and how to optimize testing and optimize the ability to keep the players from getting infected and what happens when they get infected. So I think stay tuned. We're trying to figure this all out. The Ultimate Fighting people just had a match. So that's the only sport that's actually going on right now is the UFC. But it's hard to see exactly how it all happens. And there are some people talking about soccer as well, but they've already had some exposures with soccer. So this is going to be a very challenging thing to have sports back. I know people want to have it back. I didn't realize how important it is to many people until I got put on this task force. But
well probably even more important than sports are schools. Mm-hmm. And schools and colleges. So there's a lot of concern about that. I mean, we're talking a lot about that at Carnegie Mellon, about our starting in the fall and how that will be. I know many of the parents are thinking about it. I know for my own grandchildren, thinking about whether they'll be able to go to school in the fall. So what are your thoughts on it now? When do you think it would be reasonable for schools and colleges to reopen? Some said, well, we can't open until we have a vaccine. Is that reasonable?
So a couple of things. So I would separate schools from universities as very, very different from, primary and elementary schools and high schools from colleges. So let's take the first part. The school closure was something that was very controversial and wasn't quite supported by everybody in my field, including me. Most of the data that we have on children is, and I know there's a lot, this is all shifting. And if you watch the hearings today, you probably heard some different stuff, but so it remains true that the vast majority of children who get this infection have a very mild case. There is something going on with this inflammatory syndrome that's you're hearing about, but that's a very rare occurrence, and we don't quite know what's going on and why we're only hearing about it really now and not in other parts of the world. But what we knew about children is they tend to have mild illness. They do get infected. They do have a lot of contacts with other individuals, and they do have the virus in their nose. But are they driving the epidemiology of spread? The reason for closure of schools has always been to decrease the spread in the community. And most of that data comes from influenza. And it's not even very good for influenza. And there's lots of costs to closing schools, meaning that some children rely on the schools for food. Some of them, there's psychosocial reasons, obviously, and educational reasons. It's also important for parents that need to have alternate childcare, especially if businesses are open. So all of that has to be taken into account. And we haven't seen the children driving the epidemiology here. So this is an open question. So now there are many plans to open schools back up in the fall, and I do think we can do this. It will likely be a little bit different in terms of social distancing, in terms of desks and recess and gyms and how that all works, and busing. All of that's going to have to be worked out. But we know right now that this homeschooling type of stuff is failing, that children are not learning. Even in Pittsburgh, they've had to distribute laptops and iPads because not everybody has that. Not everybody has. And if you're like a second grader, you can't necessarily know how to upload your homework to your teachers to the server, you're going to have help doing that. And not all parents can do that, have the time to do that. So there's a lot of questions about how well this works. And obviously, if you're like a student that has a very high, that has a school with a big budget, that everybody has iPads and high-speed internet, it's very easy, but not everybody does have that. And there are schools now that have already opened in Idaho and Montana. There are some schools that are back open again. And the plans are, for at least in Pennsylvania, to have the schools open in the fall. At least if the education secretary said that yesterday for Pennsylvania. But we'll see. Universities and secondary schools, things where people travel, I think that's going to be something interesting. Some schools actually might say that you got to like sequester yourself for 14 days before you go, or they may have these kind of ideas about quarantining you before you go so that you don't bring it to the campus, but it's going to be very hard to police that. I do think that universities have the advantage of people having technology and being able, they're older, they're adults, so that they can actually learn better distance wise. But I do think that they're going to have variability across the country on whether a school is open or not. I think many schools have the intention of opening, and I do think that you probably do gain more from having a campus open than trying to do everything online, especially if you're paying, Carnegie Mellon tuition and you don't get to be, you're doing it all from home. I think that's a challenge for people to have. And I think that you're going to see, I would just say, I think most universities will probably open. They probably will be much more social distancing occurring on them, and much more liberal use of distance learning and podcasts, and instead of actually attending lecture live.
Well, there are so many more questions, but let's talk a little bit first about what are the lessons we're learning now? If you had to go back in time now and give advice to us looking forward, what would you say based on our experience with COVID-19? How do we prepare for pandemics like this? What could we have done to prepare better for this one? What lessons are we learning? Are we learning the lessons that we should be learning right now?
So I think that there's this notion that this was unpredictable, that it just came out of nowhere. That's not the case. My think tank has been working on these problems since 1997, and we've written many reports. We've testified in Congress. I've even presented data at the White House before on certain things during prior administrations. So this is something that was not unpredictable. People had coronaviruses on their radar since 2003. We were overdue for a pandemic, meaning that we've got world travel at record speeds right now. We've got mega cities all over the country. We've got more human-animal interface going on all over the world. So this wasn't something that should be surprising to people, especially after what happened with SARS in 2003, and then Middle East Respiratory Syndrome, which is another coronavirus that appeared in 2012. So we had pandemic preparedness types of stuff put in place during the Bush administration, the second Bush administration, for the threat of avian influenza. But what happens is that there's this cycle of panic and neglect, that people get scared for a while and then they start to neglect it. It gets out of the headlines and those programs disappear. But we do have proper tools to use. We have diagnostic testing ability. We have very sophisticated tests that can be in place. We have huge biotech industries that can make these types of vaccines at a time. And just remember, the SARS occurred in 2003, and we're now 17 years later, and there's no vaccine for any human coronavirus. There's no antivirals. That was basically left because there wasn't any impetus to do it, because the virus disappeared, and then there wasn't a market opportunity for companies to be involved. So I do think we have to really start thinking about pandemic preparedness as something that we think of in akin to the Department of Defense or national security, that we have to start having durable, sustainable funding of programs that are looking for these viruses, that are looking for these types of pathogens, and trying to predict whether they're going to land in humans or not. And that's going to involve making sure we have an appropriate workforce, that our health departments are adequately staffed, that we have some way, a mechanism of making countermeasures against them, vaccines, drugs, diagnostics, in the same way we make countermeasures against weapons, basically, because this has really underscored how much that our national security is dependent upon being free from an infectious disease pandemic. And I think this has to be something that we do not only when there's a pandemic, but all the time, that this has to be something that is a priority, that like political candidates should talk about what their pandemic policies, what their pandemic preparedness policies are, the way they talk about other types of policies, because this is a pandemic that's touched everybody. And it was preventable at a very low cost compared to what we're spending now and what the economic losses are. So I do think that we have to learn that lesson from this pandemic. And I think people got complacent after the 2009 H1N1 pandemic because it wasn't very severe in terms of the number of deaths and disruption. And that's not the case. I think we dodged a bullet in 2009.
So as you look across the globe, what lessons are we learning from the other countries that have already experienced this, whether it's China or Korea, whether it's the UK or Italy or France? What are lessons are we learning that were done well or not done well?
Well, we have the lesson of ourselves not doing it well to learn from, not necessarily to pick on other countries who are not doing it well. But for countries that did it well, I would look at Taiwan and South Korea, for example. What they did was immediately react. As soon as they knew that there was a respiratory virus spreading in China, in the community, they automatically started saying, get ready, get our testing in order, and find these cases early, test them, treat them, isolate them, find their contacts and test their contacts, and this test, trace, isolate type of paradigm. That's what they did right. And they didn't wait. We waited January, February, till March, basically, for us to really start taking this seriously. Whereas, for example, Taiwan was working in the very first days of January to get themselves ready to deal with this. And I think that's what we have to use as a paradigm. They did it according to textbook, and it worked. We didn't do it according to textbook, even though people who wrote our textbooks are the ones running this. It's a very strange paradox that we had, because most of us, if you look at what I was saying earlier, I thought this isn't going to be a major problem. We're going to be able to handle this, because I did not think that our diagnostic test rollout would have been so bad that the testing protocol, meaning that you could only test people from China and you could only test people with evidence of lower respiratory tract disease, not the mild cases, that would constrain us so badly. I just did not think it would be bungled that badly in the beginning. I thought we wouldn't get to this position where all we had were these blunt tools of social distancing. I thought it would be much more precision strikes on where this virus was and where it wasn't. But we were flying blind because our diagnostic testing was so bad, and that's why the governors just said shut everything down, because we have no idea.
So talking about that in the testing, where are we with testing now, and contact tracing and antibody testing, all these things that are so important now for us to be able to understand?
So we're in very different places in different parts of the world, in different parts of the country. So I would say that you have a patchwork here, and there are places. So, for example, southwestern Pennsylvania, I think because of the fact that we have major healthcare systems here, we're kind of we basically have an abundance of ability here versus other parts of the country. Testing is getting better, though. We're doing about 300,000 or so tests every day in the United States. It's probably not enough yet, but the percent positive rate is like in single digits now, which is really good, meaning that you're looking harder to find tests. So that means we're doing a good job at that. We need to get better. We need to make sure that everybody that needs a test can get tested. The contact tracing is a little bit harder because that is resource intensive. That means you need to hire people, and that's going to be very different across the country depending upon how states have resourced their health departments to be able to hire people to do the contact tracing. And I think that there are efforts on board. There are efforts underway, for example, in New York State, where Michael Bloomberg is trying to make a crash training program for some of the people in New York State to do that. I haven't heard in Pennsylvania, they are trying to hire more. Ohio, they're trying to hire more. But that's going to be the key thing, is trying to make sure that our health departments are adequately resourced to be able to do this, because that's going to be one of the key factors going forward, is can we find these cases and can we do a contact trace to keep the chains of transmission to a degree that they don't end up spilling into hospitals. And I think that's going to be variable, and that's going to probably be the biggest challenge going forward. Health departments are often neglected. They're not the parts of local governments that get the most attention, but I think they need to be. They've been under-resourced for a long, long time, and they're going to be crucial as we move forward.
Do you anticipate more pandemics in the future?
Definitely. Remember, viruses and pathogens can now spread at the speed of a jet. So the more travel that we have, the more mega cities that we have, the more likely we are to have pandemics. So this is something that's not a matter of, if we have a pandemic, it's when the next pandemic occurs. And this is going to be something that happens when you have civilizations that actually, when humans move from hunter-gatherers to having settlements, that's what became it was called the age of epidemics, because that's when infectious diseases had enough density of population to be able to spread. So this is going to be a matter of a biological fact, basically, that we have pandemics. And I think we got lucky in the last 100 years, and the pandemics that we've had in 1957 and 68 and 2009 have not been bad. But I do think that this is something that we have to expect and prepare for.
When do we expect the antibody testing to ramp up to know if someone's already had it, already been exposed, and And is there really a signal now that that person would be immune to COVID going forward?
So antibody testing has been scaled up right now. You can actually get tests if you go on to Quest's patient portal. You can actually get an appointment to get your blood drawn. And I would suggest using some of the Quest LabCorp types, not some of the fly-by-night operators that are out there, because there's a lot of variability in the sensitivity, not necessarily sensitive, the specificity, meaning that some of these tests have false positives, but there are some that have good specificity out there, including the ones used by Quest and LabCorp. There's one made by Roche, which you can get. Your doctors can get them for you, or you can actually do it without a prescription now. So this is something that we're doing. The antibody test will tell you, yes, you were exposed. And we have there's strong reasons to believe that once you've been infected, that you cannot be reinfected, at least for some period of time. And that's what we've seen with many infectious diseases. When it comes to coronaviruses, we know that, remember, this is a 7th human coronavirus. There are 4 other ones that cause about 25% of our common colds. With those coronaviruses, people can get reinfected after a period of about a year. Those reinfections are clinically silent, meaning they have no symptoms. We don't know if those people are contagious. So for this novel coronavirus, we haven't done the studies yet. Obviously, we haven't done what's called a natural history study where we follow people out to see they were re-exposed, they didn't get reinfected. But I think that for the most part, we can rely on the fact that people are going to be impervious from infection, at least for some period of time before their antibody levels fall. Understanding where that falls off, several months to a year is probably where I would put it. That's going to take some time to get. We're going to have to just wait and see and follow these people and look at their antibody levels.
There's been a lot in the news lately about cardiovascular and neurological issues that are coming up as some lasting effects of COVID-19. What are your thoughts on that?
So there are people that can, so when you get this coronavirus, most people have a mild infection and they recover just like a mildly severe cold. But there are people who this virus, when it interacts with their immune system, sets off a cascade of events that leads to, for example, blood clots. And people have had strokes with this coronavirus. We're trying to understand who this happens in. It's pretty rare when it happens, but it can happen that this coronavirus can make you have clots. We definitely see it in critically ill patients in the ICU. That's more frequent. You'll find mini clots in their lungs and in their toes maybe, and there are people that do get strokes from it. It does have a cardiovascular component to it as well. Coronavirus can inflame the heart, or at least the immune system might be reacting to coronavirus and inflaming the heart, and people do have heart can get insufficiency of their heart with something called cardiomyopathy, where the heart just doesn't beat as well or as strong. And that's something that we've seen as well. We still don't quite understand who's at risk for this and who isn't at risk for this. We're just seeing these in some of the critically ill patients, these heart problems with it.
Okay, so there's a lot of questions coming in here. I just want to talk, what do you see as the impact that this might have on the future of our society and how we do business, how we do all the other things in our life? How is this going to make a lasting change for us? Is it going to be like Dr. Fauci said, we'll never shake hands again?
No, I don't think it will be that we never shake hands again. But I do think that what this pandemic is going to do is usher in some of the things that were already happening. So already, for example, retail was dying. People were using Amazon and Zappos and all those other companies. I think people that were kind of on the fence have now had to do it. So there is going to be much less use for shopping malls anymore. There's going to be much less in-person retail that happens. People are using platforms like Zoom. So there's going to be less need for in-person meetings, less business travel. People are going to be ordering their groceries online more. All of that's going to happen much more frequently. People are going to be wary about traveling and going to crowded places. So that's going to be something that changes, even without any kind of social distancing type of thing. I think that's what's going to happen, is that you're going to see people get more used to digitization of society and doing things virtually rather than in person. I think that was already happening, and now I think it's really going to be ushered in. Think about restaurants. So many people had not downloaded Uber. I had not downloaded Uber Eats until this happened. So now there's going to be people that say, well, why do I need to go to a restaurant and deal with all of that stuff with the gloves and the disposable menus and having to sit apart and do all of this type of stuff? Why can't I just order Uber Eats and eat at home or on a picnic table in a park or something? So I think that the takeout's going to become much more common even when restaurants are open, especially if they're open at diminished capacity. So I think there's going to be a lot of changes. Remember, the Black Death caused The Black Death caused the peasants' revolt and overthrew the entire feudal system because so many people died, so many lords and people died, and the peasants and people needed people to do work, and the peasants we're going to get paid now, and it overthrew the whole feudal system. So infectious diseases have that ability to change, to really uproot things in society based on who gets infected, who lives, who dies, and what types of modifications you have to do to your life to thrive. And I think this is going to happen with this pandemic as well.
Great. Are there any problems with our economic structure that this pandemic has brought to light that we need to take attention to?
Well, I think one thing that's important to remember, and I'll go back to some of my Carnegie Mellon Tepper time, is that this is not like something that you can spend your way out of. So this is a supply shock. This is, people are not producing. And you need to produce in order to live. So when you just give people stimulus checks, that can maybe get you through a little bit of you paying your rent and paying your bills. But when you think about what's happened here, that things went offline for a certain period of time, that's going to compound over time. So we're going to look back in 20 years and say, where would we have been for not this pandemic? There's going to be if you think about the compound rate of growth of a business or an economy, this is a major setback that's going to magnify because things just like compound interest, it's going to be something you see much later on. So I do think that this is going to be a major setback that's going to take decades to recover from because of what, if you look at the compound rate of growth and what this did to it, that this whole supply shock and just basically zero productivity for many parts of the economy for several weeks, 8 weeks or more worldwide.
So do you think we're learning a lesson about perhaps the overreaction on economically, or is it the fact that we just weren't prepared for the healthcare crisis that caused the economic crisis?
Well, I think it's both. We definitely were not, I think most people weren't thinking this could be this severe. This is 2020. We're not going to have some kind of problem like this. But a lot of us knew that this would happen because politicians are going to try and they're not necessarily going to be guided completely by the science. They're going to overreact. They're going to first minimize the risk and then overreact to the risk and never really right-size the risk and then create a lot of collateral damage. And I think that's the case, that people didn't realize how beneficial pandemic preparedness is in terms of cost benefit. Because if we would have done this better, we would have had much, much less disruption to industry because of this. And I do think that people are learning how important it is to think about the economic consequences. People haven't thought about unemployment levels this high for a long, long time, or seen videos of people in line to get food at some of those places where there's not food, or heard about farmers actually destroying food because they have no one to sell it to because the restaurants are closed. At the same time, people need food that you have So I think that there's a lot of eye-opening going on about what a pandemic can do to society now. And I think that hopefully we learn the lessons and prepare for this in a much better way in the future.
So do you see that there could be a good national strategy for pandemics, and what would be the federal and state responsibilities for the health crisis? So
we've had strategies. It's interesting that most people think that there isn't a strategy. There was a strategy and it just wasn't used. This is something that we've been thinking about and talking about and discussing for decades. What we think about is a federal strategy for coordination and some of the expertise at the CDC, at the NIH. And then FEMA when it gets very bad, and the FDA for countermeasures. But states have to execute most of this because pandemics and epidemics are going to happen at a local level, and much of the on-the-ground personnel that are going to be needed to do contact tracing, that are going to be needed to look at hospitals and help with hospital capacity, are at a state level. So there has to be a partnership where you don't have states competing for each other to buy personal protective equipment or flying in things from South Korea because they're scared the federal government's going to seize them. Or that's what you want. You want the federal government to coordinate between the states. And I think that's really not been the case here versus, for example, during H1N1. And there were definitely hiccups during H1N1 in 2009, but nothing of this sort where you had governors basically doing their own thing in 50 different ways because there has really been an abdication of federal leadership.
Well, do you anticipate that there's going to be this, quote, second wave anticipated in the fall, or that we're going to see outbreaks of this? And would that be expected? And what would you say our strategy should be to those?
This virus isn't going anywhere. I do think we have to think about another wave of infection because this is something that is going to basically continue to spread. And we know that this virus does have favorable environmental characteristics when we get into the colder temperatures that are less humid, less sunny. So I do think that we have to think about this being with us in the fall and winter and spring as well. And it's going to be competing with influenza at the same time for the same resources, the same hospital beds, the same ventilators, the same personal protective equipment. So it's really important this season that everybody get their influenza vaccination so that we can keep as many people out of the hospital, out of doctor's offices, out of emergency departments with influenza as we can, so we have the room to take care of the coronavirus patients.
Will this accelerate telemedicine to a new level?
Yes, I do think telemedicine was something, again, that had been on the brink. I think now you're seeing that many parts of healthcare many things in healthcare can be accomplished with telemedicine, with televisits. Not everything can, but I do think you're going to see acceleration of telemedicine now because people had to do it out of necessity, and now they're gotten used to it, and patients realize that they could probably they could see their doctor this way rather than having to drive to the office and deal with all of that headache.
So there are literally dozens of questions from N95 masks to what surfaces, all those things. Where do you send people when they ask you for advice on that? I know you can't answer every question all the time.
I think the CDC website is a good one. The Center for Health Security, where I work, has a lot of fact sheets that might be helpful. The state health departments also have fact sheets as well. That's kind of where I send most people, to those types of places.
So you've been involved in infectious diseases and epidemics and looking at this for a long time. So what's the biggest thing that you've learned in this whole process? That it's interesting because everything that you predict or you think about as a worst case scenario can sometimes happen. And being specialized in something very niche where people kind of think you're this eccentric person who worries about things that are not going to happen. It's very strange when it does happen, and then you become the person that everybody turns to. It's a lot of pressure, and it's very unnerving in many ways. But I've learned that even when you know everything, there's always going to be surprises, and human factors can definitely magnify what's going on for the better or for the worse. And that's really something that's hard to plan for or think about, is what political decisions or what policy decisions can be made that can make something worse or make something better. And that's something that we always have to think about, because even if you know all the right answers, if people aren't listening to you or people aren't taking the right actions, it doesn't matter, because you're going to end up in the same place as if they didn't know the answer. If there was one thing you could say now to our political leaders in the federal government, from the governors to the mayors, what would you say to them?
I would say that pandemic preparedness has to be something you think about every day, that this has to be the way you think about terrorism and floods and hurricanes. You need to think about pandemic preparedness. This isn't some kind of esoteric academic exercise. You can see what can happen when you get it wrong. So it's very important that you get it right.
Well, Dr. Adalja, we want to thank you for spending some of your valuable time with us this afternoon. I know we could have gone on for another hour or two and not answered all the questions, but we know we can catch you online. If they go online to YouTube, they can see some of your other videos that you've done for our students on campus and some of your other things. Thank you so much for your time today. We're very proud of you as an alumnus to making such a valuable impact to our country at this time. So thank you to all of you who joined us. Hope you can attend another one of our webinars coming up soon. We would encourage you to stay healthy, stay safe, and love your families and take good care of them. Thank you.
Thanks.